Shivangee Thorne has been a medical social worker at the Atrium Health ALS MDA clinic in Charlotte, North Carolina for the past 8 years. She helps patients with ALS and their caregivers navigating their care needs and how they cope with this disease. Thank you for joining us today, Shivangee.
Hey, everybody. I hate to be at a presentation where people just read off the slides, so I don't plan to do that. I'm happy to take questions at the end, but please feel free to ask along the way. So today, MDA has asked me to talk about different ways to think about getting a caregiver and that kind of thing. So I hope that this will be useful. Okay. I'm ready for the next slide. So as you can see, I'm just giving you a little information about myself. It's pronounced Shivangee, but I will probably respond to most things. People have said it many different ways. As Michelle said, I'm the social worker here at the Atrium Health ALS clinic in Charlotte. I've been here about 18 years. I've been a social worker for about 19 years, and that's all been in the medical field. I'm a wife, I'm a mom, I'm a person who loves, maybe needs coffee. We won't talk about that. And spending some time with my friends. I have personally lived in 2 different countries, 8 states and 12 cities, and I understand we've got good representation from around across the country and maybe even some other countries or areas. So hopefully most of this will be useful to everybody. I'm going to go to the next slide. So I think before we can talk about how to get help, we need to consider how we know if we do need help. So some of the things that I usually talk with patients about when they say, I think I might need help, is let's talk about the level of independence that the PALS has. Does the person with ALS need help with many activities of daily living? Just a few? Are there safety concerns? Kind of gauging where we're at. The other thing to consider is how much energy is the person with ALS putting out just to do simple stuff. Often we'll ask the question, are you so exhausted from getting dressed that you no longer want to go to the place that you were getting dressed for? Or are you having to do things in a way that is not very comfortable? So maybe you can do a task, but the way you do it is not comfortable. Or you're like, I can do it, but it feels precarious. Maybe I feel like I am not very safe when I do this task anymore. Or I can do it and I can get myself, for example, a simple meal, but I can't really get what I'd like, or I can't put on what I'd like, or I can't communicate in a way that I'd like because those things would require another person and that person's just not available. Or maybe my family caregiver, my spouse, my children, whoever's in my family just can't do all the things. And the last question is, what are all the many tasks that happen during the day? Who's doing them? Is it that I'm doing them for myself? Is it that somebody in my family is doing them for me? And is it something that only we can do, or is it something that someone else could do? Just because it needs to get done doesn't always have to be just us who do those tasks. There are certain things that only our spouse or our children can do for us, or that we can do for ourselves, and certain things that need to get done, but maybe an outside person could be helpful. So that kind of sets up some things to think about in terms of knowing when to think about having someone come in or not come in. So I'm going to go to the next slide. One of the things about having someone come in sometimes is that it can be a hard conversation. Either the patient with ALS or the caregiver have different feelings about this. Sometimes the person with ALS doesn't feel the need to have someone else come in. And of course, there's a lot of considerations. There's considerations about giving up body autonomy, about being independent, about having, you know, a stranger do very personal things for you. Sometimes the caregiver, family caregiver themselves feels like they should be doing that and they should be able to do it and they shouldn't need to ask for help or are having a hard time recognizing their own fatigue and need for assistance. So going into having that conversation, if you think that it might be tricky or a little bit hard, some good, you know, rules of thumb for those kind of conversations are, you know, first of all, let's find a time when everyone's kind of at their best. Let's not do things when people are sleepy, sleep deprived. If people are already having a hard time, feeling grumpy, cranky, people are hungry, we definitely don't want to have that conversation when anyone's hangry. You know, my thing is always don't talk to me if I'm hungry, sleepy, or dirty, because you'll not get the best of me. So if it's possible, having those conversations at a time where everyone's kind of at their best is probably going to be a better outcome. Go into it using, assuming good intent, right, that the person that you're having this conversation with wants the best for the situation, for each other, for functioning, and nobody is trying to blame or guilt or making anybody feel bad. Using I language. I'm concerned about you. I'm concerned that you are not safe and I don't feel I can be here all the time. Or I'm concerned about you. It seems like you're feeling kind of burnt out and I want you to be healthy. And then, you know, another thing about not assuming intent is if you ask a person, can I have a tissue? And they say no, maybe it's not that they're being selfish. Maybe they don't have a clean one. Maybe the one that appears clean isn't. So, you know, it's better to do things like ask further questions when you're not sure why somebody's answer is a certain way or they're saying a certain thing than assuming this part of the conversation obviously meant that they don't care or they don't understand or anything else, which are the things that kind of make conversations tricky sometimes. Sometimes it's hard to really get a sense either for the PALs or the CALs to have a good sense of how many tasks are really getting done and how much work actually we could ask a paid caregiver to do. So some people will do kind of an informal mini time study like, oh yeah, it really does take an hour and a half to do the morning routine, and sometimes this piece takes that long, and when we glom it all together, we realize, oh, that's a fair amount of time that we haven't noticed before. And lastly, I always say, you know, one thing you can agree upon is give having a caregiver come in a try and then reassess. Maybe it's working for you, maybe it's not, maybe you need to tinker with how things are going, but it's not a black or white. You can start something and end it. You can reimagine things as you go. So the stakes don't have to feel quite so high. All right. So the next thing I want to do on this next slide is talk about some definitions. When people start talking about having help at home, I will use terms like help at home, in-home help, custodial care, or respite care. I try not to use home health care, and the reason is that is a very specific thing under Medicare and other insurance. So home health care is skilled care, what we normally think about as a physical or occupational or speech therapist coming in to do treatments or exercises for maybe strengthening or teaching. Home health care is by its very nature meant to be temporary. The therapist or the nurse are intended to come in, do a task, either wound care or the therapies, finish the task, whatever that looks like. Someone's healed or the family is has been successfully trained to carry on, or the person has reached a plateau and the care is over. Home health care usually is covered by insurance because it is considered active medical care by a skilled practitioner, and it's something that requires a doctor's order to initiate. In-home care, or as I said, custodial or respite care, is the kind of care that doesn't necessarily require a license or a certification to provide, though sometimes people like a certified nursing assistant will provide that care, and that's an appropriate type of person to do it. But also our family caregivers are trained to do those things. Sometimes friends and family can be trained to do those things, or they're doing things like cleaning or making meals that don't necessarily require specialty skill and training. They could be doing things like helping to give a bath, making a meal, cleaning up, taking out trash, picking up groceries, what have you. That care usually is long-term, especially for patients with ALS, in the sense that generally people are arranging that care and getting it over months or years, depending upon that need. Unfortunately, in the U.S., that's not usually covered by health insurance. There are some exceptions, and I'll talk about that a little bit later, but typically it's not an insurance-covered expense, but it doesn't need a doctor's order. And so it doesn't rely on medical facts to start that care. Okay. So I know this might seem like I'm doing a left turn, but this is a question I get asked often. Well, I've heard that hospice can be really helpful, and what if I just get a hospice order? Will that give me the care that I need at home? So I wanted to address that question. And the thing is, I'm a big believer in hospice. I've worked for hospice in the past, and they are a great service. The benefit and philosophy of hospice is comfort, care, and quality of life at the end of somebody's life. In the U.S., hospice is most often administered in the patient's home. Generally, it's covered by Medicare or most insurances, and it does, like home health care, require a doctor's order. Hospice provides to its patients a primary nurse. Generally, those folks will come out to visit a patient at a minimum of once a week, more often if something is going on or the patient requires it. A nurse's aide who usually can come out 2 to 3 times a week to do things like bathing or light housekeeping or something like this. A social worker and a chaplain, both of whom will make contact and visit with patients at a minimum of once a month, and again, more if needed. Hospice also will provide medications, meaning they will order them, they will manage them, they will bring them, and they will also cover the cost of them, and also some durable medical equipment. So what that means in ALS is a little tricky. The way that Medicare pays for hospice is that they provide hospice a per diem, a daily rate for taking care of their patient. And Medicare says to hospice, hey, you're taking care of our patient. You're required to take care of all of their needs that are related to their hospice diagnosis, which means the diagnosis that they are entered into hospice under. And that includes all your staff, your medications, and durable medical equipment. Well, as you might imagine, that daily rate is not terribly high. And some equipment that patients with ALS might need or want can be kind of pricey. Here at my clinic, we work as a team to ensure that patients, as close as possible, as much as possible, can get the best of both worlds. If that means ordering the equipment and having that go through insurance first and then initiating hospice, if that means initiating hospice and providing equipment through a loaner system, or whatever else we can do to make both things happen in a timely manner. Things specifically like power wheelchairs and speech-generating devices can be tricky for hospice to provide. So we try to work on those things because we do know that they provide quality of life and comfort and assistance to the caregiver. So they're very important. The other thing that hospice will provide is that those clinicians that I mentioned earlier are available 24/7 for symptom management. Now, that doesn't mean that somebody will be at your house all the time. What that means is somebody is on call all the time. If one of their patients has symptoms out of control or a medical event, they arrange it so that the patient and family will call hospice first. One of the hospice clinicians will answer, provide ideas of what to do to manage those symptoms on the phone, and either have the family start that on and then travel out to see the family, or check back in pretty soon to make sure that those things have kind of met the patient's needs. But again, the hospice folks are not there 24/7. And so that is maybe different than what some folks anticipate. Here on this next slide, I talk a little bit about what hospice is not. So that's where I kind of started going just a second ago. So for a person who has ALS, but maybe it's not at the end of their life, they're pretty plateaued and they're doing okay. Or for folks who maybe want to consider pursuing aggressive medical measures, like having a tracheostomy placed at the time where that might be necessary, hospice may not be the right route for all patients. Hospice is a program whose aim, as I said, is to provide comfort care, quality of life, and really focused on less medical intervention and more comfort interventions for people at home. And again, they're not a caregiving agency. Total, their staff is probably available for about somewhere between 2 and 5 hours a week, and not 24/7. A lot of hospices will have a hospice house. Those are generally used for if a patient is having some sort of symptoms that are not able to be controlled at home and they feel like they can do a better job of that in their facility. Honestly, in my experience, a lot of our ALS patients don't experience that. And there are usually some availability for respite, but that's quite limited. So most of the time, those receiving hospice will be at home. Folks who are on hospice will also probably need to consider hiring caregivers at some point or another, so this information could still be useful. I'm going to move to the next slide. So here are some things that you and your family and your care team might want to think about before you arrange some help at home. We discussed earlier, what kind of help do you need? Is it bathing, dressing, and personal care? Is it just supervision in case you were to have a fall or need to get out of the house or have trouble getting your Trilogy or BiPAP mask on and off? Are there specific tasks you'd like help with? Making phone calls, doing computer work, eating a meal, getting out at certain times? Do you need help getting out and about to do errands? Or I've had people have a caregiver be the driver so that they can still pick up children or grandchildren as their normal routine had been. And some people might need care with specialized equipment like a feeding tube or a ventilator. So knowing exactly what kinds of help you might need will help likely to figure out what kind of caregiver you're looking for and how to go about finding them. So here on the next slide, I got some pictures. One thing that I always talk to patients about when we're talking about getting a caregiver is, what assistance can your clinic staff provide? And I don't mean that your clinic staff will necessarily come to your house and be there to bathe you, but I do mean, could some of the things that they provide give enough respite or support to you and or your family caregiver that you may need a private caregiver for less time or not quite yet? So you may see things here, pictures like this gentleman on the upper left who's using what we call a Hoyer lift or a patient lifter to help move a patient. And on the bottom left, there's a pancake button for using as a way to call somebody for help. You can see a shower chair, a speech generating device, a power chair, any number of things. I really, really believe in utilizing our whole team, making sure that as many people on our team have talked to you about all the options that are available so that things are as easy as they can be and as manageable. So I'm going to move to the next slide. But here's the real question, right? Here's the reason why you're hopefully watching this presentation. How do I really find someone? So generally there's two options. One is to go through an agency, and there are nursing agencies pretty much nationally that do these kinds of tasks, and or you could use just a private person who likes to do this kind of work. So there's obviously advantages and disadvantages to both. With an agency, they will hire, fire, manage, insure, and hopefully bond the employees. They are responsible for providing a backup person if someone calls out. And they will usually talk with the patients about and families about finding a good fit. Their hourly rates, though, could be a little bit costlier, and they sometimes have rules about both the kinds of tasks that their employees are allowed to do and or, they will only arrange care if for a minimum of 3 or 4 hours or certain times a day or something like this. With a private caregiver, there can be a lot more flexibility in terms of hours and tasks that that person's willing to do. Maybe they're willing to drive somebody around. Maybe they're willing to learn how to use a feeding tube, whatnot. And maybe they're willing to do 2 hours in the morning and 2 hours in the evening, and that's okay with them. And their hourly rate could certainly be kind of lower overall, and yet all the money's going to them versus some going to an agency. On the other hand, if that person can't come to work or chooses to stop coming to work, it's up to the patient and family to figure out a backup plan and have an alternative option in mind. So, agencies and or private caregivers work for different people, and I've seen people do a mix of both. So here on the next slide, as I said, Many patients will use a combination of private caregivers and agency assistants. Maybe you found an agency that you feel comfortable with and you really like their caregiver, and that person's available 3 days a week, but you're going to use somebody you have heard of for another 2 days, or vice versa. There are a lot of national agencies that specialize in this kind of care. I normally have that kind of information available at our clinic for our patients who's local to our area. I would say either your local clinic social worker, program director, MDA rep may have that kind of information. And then the other way to find care is word of mouth. Are you in touch with other patients and families? Do you know folks in your neighborhood or your family or your house of worship who have used caregivers and can tell you, yeah, that's a great person, or I don't know about that. And then sometimes people will use online platforms like care.com. I have a family member, patient's husband, who swore by the folks he found from Craigslist. Some people will use neighborhood social media platforms. I've known of folks who will hire students who are in nursing school or OT school who will come and do this kind of work for a few hours every afternoon or something. So here on the next slide, I'm going to talk a little bit about how do I know that this person's the right person for me? Regardless of what glowing recommendations you get from somebody else, regardless of how you may know them, it's important to do a full interview with them. And, you know, interviews are always two ways. They are getting to know you and what you need to determine if they feel like they can do those things, and you will find out if you feel like that person's a good fit for you. And before you have someone come over, as I said before, maybe make a list of specific tasks. Notice over the days and weeks before someone comes the kinds of things that you're generally asking someone for help with or someone else is helping with. And also those things, as I said before, that it would be nice to have help with. For example, we had a patient who was doing okay and kind of having a simple breakfast and sandwich for lunch, but said, you know, it would be nice to have something hot every once in a while. And so, again, that was not a, you know, desperate need in the sense of a safety concern, but it is a comfort issue. It's helpful to ask if those folks have ever taken care of somebody with ALS. It doesn't have to be 100% rule out if they haven't, but it's nice if they have some experience because obviously we know that ALS looks different than other diseases, and it's nice if they have some frame of reference. And, you know, as many of you know from being in the workforce, it's a lot easier for us to be successful at our job if the instructions we receive are very specific. If you have a specific way you like to do things, you have a routine that's worked out for you, when you are training somebody, you'll have to be specific about that. Talk about money up front. In the U.S., the average hourly rate varies anywhere between $10 to $30 an hour. There's a seniorcare.com website that kind of talks about what's the average rate in your area, so that could give you a better sense of what's the going rate and what's reasonable. Talk about the hours that you'll need somebody. Do a quick walkthrough of your home and your space, and find a way if you can do a background check or call references. I know websites like care.com will let you pay for a certain level of membership and look at background checks. Be prepared to use or meet several different caregivers before you find the right fit. That doesn't mean that the idea of finding a caregiver is not going to work out. It just means that person may not have been the right match for you. The care that these folks will do is very personal, and it just takes a little trial and error to get to a person that you feel comfortable with and that can meet your needs. And again, that doesn't mean that it's not possible, but it's normal. Sometimes it just doesn't click right away. Sometimes it does, and that's great. So don't give up if it's not working just in the beginning. All right, let's talk about everyone's favorite topic, money. What does insurance pay for? So I'm just going to go through kind of different kinds of payers. So when I say commercial health insurance, I mean things like Blue Cross and Blue Shield, Aetna, Cigna, the kinds of things maybe we get through buying our own insurance or through being employed. Medicare Advantage plans are usually provided by those same kind of commercial companies, so I put them together, and they may cover the cost of this. What I have been seeing is that some bigger employers, and here in Charlotte, Bank of America is one of our biggest employers, will sometimes cover the cost of this kind of in-home personal custodial care. Some Medicare Advantage plans are increasingly adding that as one of their benefits. So when you sign up for Medicare year to year, it may be something that's worth asking about. They may not, but I say it never hurts to ask. The best way to do that is to, if you have a commercial plan already, is to call member services, ask for a case manager to be assigned, because they're more likely to know the ins and outs than the frontline person at the call center, and then ask them, do I have benefits for personal, custodial, or respite care? If you ask them about home health care, they will say yes, because virtually everyone covers in-home nursing, PT, or OT, but that's not the kind of thing that we're talking about here. Medicare, unfortunately, does not cover in-home unskilled care. They only cover the skilled kind of home health. Medicaid, most likely in most places, does cover in-home care to varying degrees. Either ask your clinic social worker or your Medicaid case manager how that works and what needs to happen. Usually probably some orders need to get sent. There may be some waiting lists, but there may not be, so that's always a good thing to investigate. And for our veterans out there, the Veterans Administration definitely provides this kind of care. Talk again to your VA social worker or your clinic social worker, and they can walk you through the process. Again, there'll be some paperwork, but it can certainly help with that respite piece. In this next slide, I'm going to talk a little bit about other funding options. So some people have in the past bought long-term care policies. So certainly contact your policy provider, review your policy. Every policy is written differently. They have different requirements. Some will allow you to use a personal caregiver. Some will insist on using an agency. Some have copays. Some have a per diem amount. They're all really different. If you're at a point where you don't need that in-home care quite yet, but you do have a long-term care policy, now is a great time to pull it out and review it so you know what you have available when the time comes. Many local departments of social services can get different grants at different times that will pay for some in-home care. So contact your local department of social services, or again, ask your clinic staff if they know how that works. There are some grants, some that will be just local to your area, and some that are ALS specific nationally that can help with the cost of caregiving. A lot of them work such that it's a reimbursement situation where you would pay up front and they would provide reimbursement, but some may be able to provide some monies up front to cover the cost. And if none of that really meets your needs, or you still have some out-of-pocket expenses, I always suggest people talk with their tax preparer to see if any of that could be tax deductible on the back end, sort of towards the end of the year. I'm going to talk a little bit more about other kind of funding or creative uses options here in this next slide. So friends and family. that can happen in a couple of different ways. I mean, some people certainly have done crowdsourcing or fundraising with family and friends, and that has helped with the cost of this, and that's great. That's certainly one way. But another thing is to use friends and family instead of necessarily hiring as much help. So a lot of people may have said to you, hey, let me know what I can do to help, or I'm here if you need anything. It can be a little hard to know if that's sincere, if they really mean it, what are they really up for. You're not sure how to ask. A lot of us are really bad about asking for help. I certainly can be. So one way to kind of do that is start either a caring bridge, or there's this online platform called lotsahelpinghands.com. Once that's started and the tasks and the calendar are up there, and you've kind of put the word out there that you have this, people who sincerely want to be able to be helpful and are offering service can just go on there and sign up for shifts or sign up to do certain tasks. And those who are more available for emotional support may not do that. And then it's a little less awkward, and it's a little less of you having to keep up with who may or may not be available. And this is also a great thing if there's a friend or a loved one who lives out of town or out of state who wants to be helping in a lot of ways, because they're online platforms and they can be managed from anywhere. And that's also true of managing things like grant applications or paperwork with long-term care companies or the VA or whatnot. So those are other ways to kind of use those groups of folks in your life. And I know a lot of patients have had good luck with this kind of thing. It also prevents things like 5 people showing up on one day and no one coming for the next 2 weeks, and helps it to be a sort of manageable schedule, hopefully. And I'm just going to wrap it up here just to say that the conclusion really is there's different solutions for different folks. There's lots of different options. So kind of thinking through what makes sense for you might be the best way to manage this piece of your needs.
Thank you so much.